accurate assessment of the functional integrity of prosthetic heart valves is a clinical challenge that can be answered comprehensively with echocardiography. As with native valvular stenosis, the addition of Doppler has been a tremendous advance in delineating the hemodynamics of prosthetic valve function and dysfunction. The more recent application of flow imaging and transesophageal echo to the study of prostheses has been particularly useful for assessing prosthetic regurgitation. By using an approach which integrates all of these modalities, we can completely solve most diagnostic problems related to valvular prostheses. The study of prosthetic dysfunction is complicated by the large variety of prostheses, each of which comes in numerous sizes and can be implanted as replacement for each of the 4 native valves. In addition, there is a large variety of pathology that can beset the patient with a prosthesis. Prosthetic valve stenosis can result from a prosthesis that is undersized relative to the patient, or can result from structural abnormalities such as thrombus formation or pannus ingrowth. Prosthetic regurgitation can be either perivalvular or transvalvular. This latter, for mechanical prostheses, can result from thrombus that prevents the poppet from seating properly, or from variance in the shape of the ball or disc. For bioprostheses, transvalvular regurgitation usually results from leaflet degeneration. Both perivalvular and transvalvular regurgitation can result in shearing of red cells with intravascular hemolysis. Finally, prosthetic valves are subject to infective endocarditis and all of its sequelae, including valve ring abscess. Cardiac symptoms arising in patients with prosthetic valves may not necessarily be due to the prostheses. In addition to fully characterizing prosthetic valve function, a complete echocardiographic exam will define associated lesions of native valves, chamber sizes and ventricular function, pulmonary artery pressure, atrial thrombi, and pericardial effusion or hematoma. Challenges facing the echocardiographer in assessing prosthetic valves include difficulty in imaging prostheses by 2D echo because of the dense sewing ring and dense reverberations from the prosthesis. Furthermore, poppet excursion on the 2D exam is in part dependent on how the prosthesis was inserted. Color flow imaging of prostheses is difficult because of attenuation of the sound beam by the prosthetic material, which can create flow masking. From a hemodynamic standpoint, it is necessary to establish whether or not the simplified Bernoulli equation can be applied to prosthetic valve gradients, and it is necessary to establish normal values for the many different types and sizes of prostheses. We will begin our discussion with normal prosthetic valve appearance on the 2D exam and normal color flow imaging. We will then discuss validation of the simplified Bernoulli equation for prostheses, and we will illustrate normal prosthetic valve hemodynamics. The discussion of normal hemodynamics will be followed by a discussion of pathologic prosthetic valve stenosis. Next, we will illustrate a systematic approach to prosthetic regurgitant lesions, and we will conclude with a discussion of valve ring abnormalities. We will begin our illustration of normal prostheses with the ball cage variety. This 49-year-old female has Starr-Edwards mitral and aortic prostheses. Throughout this tape, we will use this type of abbreviation to indicate a prosthesis, which in this case is a mitral valve replacement. This is the sewing ring, and this is the tip of the cage. This is a systolic frame. These echoes represent the leading edge of the ball within the cage. This is the trailing edge of the ball. From this image, the ball appears to be elongated with a large portion outside the cage in the left atrium. The ball is displayed like this because echocardiographic instruments are calibrated to measure distances according to the speed of sound through tissue. Since the speed of sound propagation through the prosthetic material is significantly slower than the speed through tissue, therefore the poppet is displayed with this artifactual elongated appearance. In this diastolic frame, echoes are noted in the left atrium. These are reverberations from the prosthesis. Each type of prosthesis has its own characteristic reverberations. As each prosthesis is inspected, the echocardiographer should determine if there are any other extraneous echoes that might represent vegetations or thrombus. In addition, the echocardiographer should see if poppet excursion is normal and if the sewing ring is stable and free of rocking motion. Motion of prosthetic valves can be precisely analyzed using M-mode. This recording was made from an apical transducer position with a sound beam directed at a Starr-Edwards mitral prosthesis. This is the leading edge of the ball in systole, and this is the trailing edge. Here the ball is moving toward the apex to its open position, and here it is closing again with the next systole. Opening and closing clicks are recorded on the phonocardiogram. Returning to the 2D exam, we will demonstrate normal color flow imaging for a mitral Starr-Edwards prosthesis. Blood from the left atrium enters the left ventricle around the ball in the form of a jet or spray. In 2 dimensions, this spray has the appearance of a pair of horns surrounding the ball. Note that there is no evidence of mitral regurgitation. Prosthetic valves should always be scanned from multiple tomographic planes. Here the transducer has been tilted inferiorly to image the inferior portion of the sewing ring. The sewing ring does not appear to be separated from the mitral annulus, and there is still no evidence of regurgitation. Now we have narrowed the 2D sector to increase the frame rate and more clearly delineate flow through this mitral ball cage prosthesis. This is the same patient. The transducer has been rotated to develop this apical long axis view. This is the mitral prosthesis, and this is the aortic ball cage prosthesis in diastole. This is the leading edge of the ball. Aortic prostheses are typically more difficult to image than mitral prostheses. Poppet motion is identified via the to and fro motion of the mass of reverberations within the aorta. The transducer has been tilted slightly to inspect the aortic sewing ring. There is no evidence of dehiscence. Flow imaging demonstrates a jet which travels around the ball and into the aorta. This flow below the aortic prosthesis in diastole represents the normal antegrade flow through the adjacent mitral prosthesis. There is no prosthetic aortic regurgitation. This 52-year-old female has an aortic Starr-Edwards prosthesis, which is being imaged with the transducer in the suprasternal notch. From this position, the jet originating from the prosthesis is more clearly delineated, since the ultrasound beam does not have to cross the prosthesis before encountering the jet. This is an apex-down, 4-chamber view from a 62-year-old male with mitral and tricuspid Starr-Edwards prostheses. The mitral and tricuspid poppets are moving freely. The transducer has been tilted inferiorly to image the tricuspid sewing ring. There is no evidence of dehiscence. This 63-year-old female also has mitral and tricuspid Starr-Edwards prostheses. She had severe tricuspid regurgitation prior to insertion of the prostheses. On this scan, at the level of the tricuspid sewing ring, note the marked enlargement of the coronary sinus due to the previous severe right atrial hypertension. Flow across the tricuspid prosthesis is normal by color Doppler. This is a transesophageal echo from the same patient with mitral and tricuspid Starr-Edwards prostheses. In early systole, color flow imaging demonstrates flow into the left atrium directly above the mitral prosthesis. This is the normal closing volume of the prosthesis, the volume of blood displaced by the poppet as it closes. In real time, you will see that the closing volume appears only in early systole. It is not holosystolic. Now we are directing attention to the tricuspid prosthesis. In early systole, we again appreciate the volume of blood that has been displaced by the prosthesis into the right atrium. In real time, this closing volume will appear as puffs of color within the right atrium. It is important to distinguish the closing volume from pathologic transvalvular or periprosthetic regurgitation, both of which are holosystolic. This 42-year-old female has a Bjork-Shiley mitral prosthesis and a bioprosthesis in the tricuspid position. At this time, we will focus attention on the mitral prosthesis. This is the sewing ring, and this is the disc in the fully opened position. In systole, A characteristic rectangle of reverberations is seen in the left atrium behind the closed disc. Note that the patient's prosthesis is normally functioning, but LV function is severely reduced. This 30-year-old female also has a mitral Bjork-Schiley prosthesis. This is a normal color jet from antegrade flow across the prosthesis. In this diastolic frame, the open disc creates a small filling defect within the color map. Flow occurs through both the major orifice and the minor orifice, and then the two jets merge into one as they pass the tip of the disc. This apex down 4-chamber view is from a 69-year-old female with a St. Jude mitral prosthesis, which has two metal discs. In systole, there is a block of reverberations in the left atrium behind the closed discs. This is similar to those which we saw with the Bjork-Schiley prosthesis. In diastole, we see both discs opened, with linear reverberations behind each disc. There is moderate left atrial enlargement and mild right atrial enlargement. The left ventricle is normal in size and function. We are now using the regional expansion system to more clearly visualize the motion of the discs. In this diastolic frame, the discs are fully opened. In real time, you will notice that the lateral disc closes slightly before the medial disc during several cardiac cycles. By capturing several cardiac cycles on cine loop, we can use the trackball to investigate disc motion frame by frame. This study is from a 56-year-old female with a Carpentier-Edwards heterographed mitral prosthesis. The stents are usually oriented toward the septum. As with mechanical prostheses, the echocardiographer should answer several routine questions during evaluation of a bioprosthesis. Are there any extraneous echoes that might represent vegetations or thrombus? Are the leaflets normal in thickness? Do the leaflets open fully? Is there any prolapse or flail motion beyond the sewing ring? Is the sewing ring stable, or is it separated from the annulus and rocking? Here, left ventricular size and function are normal. The left atrium is moderately enlarged and free of thrombus. This is the 42-year-old female whose mitral Bjork-Schiley prosthesis was previously demonstrated. At this time, we want to direct your attention to the normal Ionescu-Schiley heterographed prosthesis in the tricuspid position. Although the cusps appear somewhat echodense, the opening is normal and there is no prolapse. This 73-year-old male also has a tricuspid heterographed prosthesis. The color flow image in diastole is identical to that of mild tricuspid stenosis, with a central blue zone representing color aliasing. This is due to the small gradient created by the prosthesis. Incidentally noted is trivial regurgitation across the valve. The right atrium is moderately enlarged without thrombus. A fresh frozen aortic homograft prosthesis was selected for this 21-year-old male. In this apical long axis view, you will see normal opening and closing of the aortic cusps. Left ventricular size and function are normal, and note also that the mitral valve is normal. By now, you have appreciated that it is much more difficult to image prostheses than it is to image native valves. This is particularly true for the mechanical prostheses with their multiple reverberations. The addition of Doppler has therefore been exceptionally useful for the evaluation of prostheses. Prior to discussing examination of prostheses by spectral Doppler and normal values for prosthetic valve gradients and orifice areas, we will detail the verification of the simplified Bernoulli equation for prosthetic heart valves. On previous tapes in this series, we have demonstrated use of the simplified Bernoulli equation to assess stenosis of native valves. We can apply this same equation to the study of prostheses. In a Mayo Clinic study, Dr. Darrell Burstow performed continuous wave Doppler examinations of prostheses, and the velocity spectra were recorded simultaneously with pressures from invasive catheterization. The study group was made up of 36 patients with 42 prostheses. There were 20 mitral and 20 aortic prostheses, as well as 1 tricuspid and 1 pulmonic. There were 32 mechanical prostheses and 10 bioprostheses. The mechanical valves included 15 Starr-Edwards, 7 Bjork-Shiley, 4 Braunwald-Cutter mitral prostheses, 2 Hall Medtronic, 2 St. Jude, 1 Sorin, and 1 Smiloff-Cutter. This record is from a patient with a Starr-Edwards aortic prosthesis. As with stenosis of the native aortic valve, Doppler will not provide the peak-to-peak gradient for prostheses, since the 2 peaks do not occur at the same time. As you will recall, the aortic peak is delayed compared to the peak of ventricular pressure. The maximum Doppler velocity correlates with the maximum instantaneous difference between left ventricular and aortic pressures. More importantly, the Doppler mean gradient correlates closely with the mean gradient obtained by catheterization. It is important to realize that in order to invasively obtain the same mean gradient that was measured with the non-imaging CW probe, 1 catheter had to be passed to the ascending aorta, while left ventricular pressure was obtained by either transeptal technique or by direct transthoracic puncture of the left ventricle. For all 20 aortic prostheses, there was an excellent correlation between the catheter mean gradients and the Doppler mean gradients. The R value is 0.94, and the standard error of the estimate is 3 millimeters of mercury. For 12 of the 20 mitral prostheses, the mean gradient was determined by transeptal catheterization with a direct measurement of left atrial pressure, while a second catheter was used to measure left ventricular pressure. As you can see in this study from a Starr-Edwards mitral prosthesis, the Doppler mean gradient correlates closely with the catheter mean gradient. When a transeptal catheter technique was utilized, the Doppler mean gradients were nearly identical to the catheter mean gradients. The R value is 0.97 with a standard error of the estimate of 1.2 millimeters of mercury. However, the correlation was poor when Doppler mean gradients were compared to catheter mean gradients obtained by using pulmonary capillary wedge pressure instead of direct measurement of left atrial pressure. For these 8 patients, catheterization significantly overestimated the true mean gradients. The overestimation of mitral prosthetic gradients by catheterization using pulmonary capillary wedge pressure is illustrated by this case. This patient was identified as having a 9 millimeter mean gradient across a 29 millimeter Bjork-Scheile mitral prosthesis, using the difference between pulmonary capillary wedge pressure and left ventricular pressure. However, the mean gradient was only 3 millimeters of mercury by simultaneous Doppler evaluation. Note that the Doppler pressure half-time was also normal, 80 milliseconds. When left atrial pressure was directly measured using a transeptal technique, the mean gradient by cath agreed with the mean Doppler gradient, both at rest and following pharmacologic increase in the heart rate. Therefore, in order to invasively obtain the same mean gradient that can be measured non-invasively with CW Doppler, puncture of the atrial septum must be performed. Use of the wedge pressure can lead to serious overestimation of the mean mitral gradient. These are the combined results for all prostheses, mitral and aortic. The Doppler and catheter mean gradients had an R value of 0.96 and a standard error of the estimate of 3 millimeters of mercury. For aortic prostheses, we utilize spectral Doppler to obtain the maximum velocity, which correlates with the maximum instantaneous gradient, the mean transvalvular gradient, the dimensionless obstruction index, which is the velocity in the LV outflow tract divided by the maximum velocity, and the effective orifice area. We will now illustrate these measurements. This patient has Bjork-Scheile mitral and aortic prostheses. As usual, it is difficult to clearly delineate the aortic disc. The non-imaging transducer in the apical position has been directed toward the aortic prosthesis. These are the opening and closing clicks. The maximum velocity is 3.5 meters per second. In this freeze frame, the clicks from both prostheses are recorded. Mitral closure, aortic opening, aortic closing, and mitral opening. The aortic velocity spectrum has been traced to obtain the mean gradient, which was 27 millimeters of mercury. This is in the high normal range for a 21 millimeter aortic tilting disc. In 1988, Reisner and Meltzer reviewed the literature for Doppler evaluation of prosthetic heart valves in patients who were clinically normal. They published the accumulated data for over 1,000 prostheses. Of these, 494 had aortic prostheses. The maximum instantaneous gradient had been calculated for each prosthesis using the simplified Bernoulli equation. This is a comparison of the mean value and standard deviation for the maximum instantaneous gradient across several different types of prostheses. Included are Starr-Edwards, St. Jude, Ionescu-Shiley, Bjork-Shiley, Carpentier-Edwards, and Hancock. As you can see, the maximum gradient across Starr-Edwards valves is, in general, higher than the gradients across each of the other valve types. When evaluating the hemodynamics of prosthetic valves, it is important to be mindful of the valve size. In this graph, Reisner and Meltzer display the peak gradient for 5 different sizes of aortic Bjork-Shiley prostheses. These are the number of patients with each size valve. As you would expect, there is a significant decrease in the maximum instantaneous gradient as the valve size increases. This is a similar graph for a bioprosthesis, the Carpentier-Edwards heterograft. Once more, we observe a significant decrease in maximum gradient with increasing valve size. This same trend was also found for mean gradients across these prostheses. As with stenosis of the native aortic valve, it is important to utilize multiple transducer positions when establishing maximum instantaneous and mean pressure gradients across aortic prostheses. In addition to the apical position, right peristernal positions should be used. For completeness, the transducer should also be placed in suprasternal, left peristernal, and subcostal positions. In each position, fine manipulations of the transducer should be made until the maximum spectral envelope is obtained. Returning to the patient with the Bjork-Shiley aortic prosthesis, you will recall that with the transducer in the apical position, the maximum velocity was 3.5 meters per second, and the mean gradient was 27 millimeters of mercury. Here, the non-imaging probe has been placed at the right sternal border with the patient in the right lateral decubitus position. In this position, the velocity spectrum was maximized. The maximum velocity is 4.1 meters per second, and the mean gradient is 34 millimeters of mercury. These values are high for a Bjork-Shiley prosthesis, which could relate to either pathologic stenosis or to the prosthesis being undersized for this particular patient. As a rule, once the transducer position for the maximum velocity has been identified, it should be noted in the report. This will facilitate future studies on the same patient. As with the native aortic valve, the gradient across a prosthetic aortic valve is not always clearly indicative of the degree of obstruction. A patient with a low output state can have severe obstruction despite a relatively low mean gradient across the aortic prosthesis. And a patient with a high output state can have very little obstruction despite a relatively high gradient. For patients with reduced or with hyperdynamic left ventricular function, it is particularly useful to calculate the aortic prosthesis effective orifice area. You will recall that the continuity equation is used to calculate native aortic valve area. We can apply this same equation for prosthetic valves. We need to first determine the left ventricular outflow tract area. When possible, a direct measurement of the systolic LVOT diameter should be made from the 2D exam. This is an expanded view of the LVOT. This is the sewing ring of a 21 millimeter Carpentier-Edwards aortic bioprosthesis. The cusps were difficult to visualize in this view. A single cardiac cycle has been captured on Cineloop. A systolic frame has been selected. One cursor was placed at the junction of the sewing ring with the ventricular septum, and the second cursor has been placed at the junction of the sewing ring with the anterior mitral leaflet. The LVOT diameter is 21.1 millimeters. This is essentially the same as the external diameter of the sewing ring. Once the LVOT diameter has been measured, we square it and multiply by the constant 0.785 to obtain the LVOT area. After calculating the LVOT area, we need to obtain the time-velocity integral of flow through the outflow tract. For this, we use the apical long axis orientation and position the sample volume in the outflow tract just below the aortic prosthesis. The examiner must take care not to place the pulsed wave sample volume too close to the prosthetic aortic valve sewing ring. This is an expanded apex-down view of the LVOT and ascending aorta. This is the sewing ring of the same Carpentier-Edwards prosthesis that we used for demonstration of the LVOT diameter measurement. Color flow imaging shows the expected jet beyond the prosthesis in the ascending aorta. This is the sewing ring. There are dead water zones near the edges of the ring, which result in acceleration of blood in the central zone, as indicated by the color aliasing. Note that this begins almost 1 centimeter proximal to the sewing ring. For the continuity equation calculation of aortic valve area, we want to measure the LVOT velocity proximal to this zone of aliasing, back here where the velocity is more uniform across the entire LVOT diameter. This is the same patient. The small image is an apex down display of the apical long axis view. The pulsed wave sample volume is positioned near the sewing ring of the aortic prosthesis. The resultant velocity spectrum aliases at 1.5 meters per second. Now the sample volume has been moved to a more proximal position in the LVOT. The spectrum no longer aliases. The patient is in atrial fibrillation and the velocity varies with cycle length. It averages 1.2 meters per second. This is the velocity we would use for the effective orifice area calculation. Having obtained the LVOT area and LVOT velocity, we need the time-velocity integral of flow through the prosthesis. For this, we use the maximum velocity spectrum obtained by placing the CW transducer in the multiple transducer positions that we referred to earlier. In this example of a St. Jude prosthesis, we are illustrating the most common situation where the maximum spectrum is obtained with a transducer in the apical position. This is the CW velocity spectrum across the Carpentier-Edwards aortic prosthesis, for which we have already measured the LVOT diameter and LVOT velocity. For this patient, the maximum velocity spectrum was identified using an apical transducer position. The maximum velocity is 3 meters per second. From the continuity equation, the effective orifice area of an aortic prosthesis is obtained by multiplying the LVOT area times the TVI of the LVOT and dividing by the TVI of flow in the aorta that was obtained with CW Doppler. As with native aortic stenosis, this calculation can be simplified by using the peak velocity in the LVOT and the peak velocity in the aorta instead of the time velocity integrals. For our patient with the Carpentier-Edwards aortic prosthesis, the LVOT diameter was 2.1 centimeters, which yields an LVOT area of 3.46 square centimeters. We multiply this times the LVOT velocity, 1.2 meters per second, to complete the numerator of our valve area calculation, 4.15. This is divided by the maximum velocity across the prosthesis, 3 meters per second, to yield the effective orifice area, 1.4 square centimeters. This 58-year-old male has a Starr-Edwards mitral prosthesis and a Bjork-Shiley aortic prosthesis. It is not always possible to measure the LVOT diameter in the presence of a mechanical aortic prosthesis, particularly if the patient also has a mitral prosthesis. In this situation, we use the external diameter of the aortic sewing ring as an approximation of the LVOT diameter. This patient has a size 25 Bjork-Shiley prosthesis, which means that the external diameter of the sewing ring is 25 millimeters, or 2.5 centimeters. This is an apex up, apical long axis view from the same patient. In order to determine the left ventricular outflow tract velocity, it is important to align the image such that the Doppler cursor can be dropped straight down the screen and be parallel with flow in the LVOT. By properly aligning the image like this, we avoid an angulation error in the measurement of the LVOT velocity. The small image shows the Doppler cursor crossing the LVOT. The sample volume is just about to enter the LV outflow tract. In real time, you will notice an increase in the velocity as the sample volume is advanced into the outflow tract. This sample volume position, just below the aortic prosthesis, is the one we want to use to obtain the LVOT velocity. As previously discussed, if we advance the sample volume too far toward the sewing ring of the prosthesis, the LVOT velocity will show a sudden, marked increase, as we will now illustrate. With this sample volume position, the LVOT velocity has increased to 1.35 meters per second. Using this value in the continuity equation would yield a falsely large effective orifice area. We have now withdrawn the sample volume slightly so that we have obtained a stable velocity pattern. The sample volume is in the LVOT below the aortic prosthesis. The LVOT velocity is 1 meter per second. For this patient, the maximum velocity across the prosthesis was also detected with the non-imaging transducer in the apical position. The velocity spectrum has been traced. The maximum velocity is 2.2 meters per second, and the mean gradient is 10 millimeters of mercury. For reference, the mean gradient across this Bjork-Shiley aortic prosthesis is 10 millimeters of mercury. The external sewing ring diameter is 2.5 centimeters, which we will use in place of a measured LVOT diameter. The LVOT area is 2.5 squared times 0.785, or 4.9 square centimeters. The LVOT velocity is 1 meter per second. So the numerator for the valve area calculation is 4.9 times 1.0, which of course is still 4.9. We divide this by the maximum velocity across the prosthesis, 2.2 meters per second, and we arrive at an effective orifice area of 2.2 square centimeters. Although this method has not been validated to the same extent for prostheses as it has for native valvular stenosis, we still find it to be a clinically useful adjunct to the mean gradient when assessing and following patients with prosthetic aortic valves. Although it is usually easier to image mitral prostheses than it is to image aortic prostheses, The addition of Doppler hemodynamics has nevertheless become an invaluable adjunct to imaging in the assessment of prosthetic mitral valves. For mitral prostheses, we routinely measure the early peak velocity, or E velocity, the mean gradient, the end diastolic gradient, the pressure half-time, and the valve area. In addition, we always attempt to obtain a tricuspid regurgitation velocity so that we can determine the pulmonary artery pressure, as was discussed on tape number 9 in this series. This is a continuous wave spectrum from the 42-year-old female whose Bjork-Schiley mitral and aortic prostheses were previously displayed. For assessment of her mitral prosthesis, the non-imaging transducer has been placed at the apex. This is the mitral opening click, and this is the closing click. She is in atrial fibrillation, so we find an early velocity peak without a late atrial peak. The calibrations are 1 meter per second. The peak velocity is 2.3 meters per second, which yields a peak gradient of 21 millimeters of mercury. The velocity spectrum has been traced. For mitral prostheses, it is important to use a low filter setting so that the flow velocity can be traced throughout diastole to the closing click. Failure to do so will result in a falsely elevated mean diastolic gradient. In this case, having traced the entire envelope, we obtain a mean gradient of 6 millimeters of mercury. Particularly for patients in atrial fibrillation, these same measurements should be made for at least 5 cycles, and the results should be averaged. By analogy with stenosis of the native mitral valve, prosthetic mitral valve areas have traditionally been calculated using the pressure half-time method. For this same Bjork-Schiley mitral prosthesis, the deceleration slope has been traced. The pressure half-time is 114 milliseconds. The constant, 220, is divided by this pressure half-time, which yields a prosthetic mitral valve area of 1.9 square centimeters. In their review of the literature relating to Doppler evaluation of normal prostheses, Reisner and Meltzer identified 568 mitral prostheses. This graph from their article compares the effective orifice areas calculated by the half-time method for various prostheses: St. Jude, Carpentier-Edwards, Bjork-Schiley, Ionescu-Schiley, Starr-Edwards, Lillehei-Castor, Hancock, and Beale. These are arranged in order of decreasing valve area. Despite having a ball cage mitral prosthesis for 5 years, this patient has remained in sinus rhythm. By CW Doppler, the early velocity peak is 1.5 meters per second, and the atrial velocity peak is 1.8 meters per second. The end diastolic velocity at the closing click is much lower, 0.3 meters per second, indicating no end diastolic gradient. The velocity spectrum has been traced, and the resultant mean gradient is 4 millimeters of mercury. The deceleration slope has been traced, yielding a pressure half-time of 136 milliseconds, which equates with a mitral valve area of 1.6 square centimeters. All of the prosthetic valve hemodynamics that we have mentioned for both aortic and mitral valves can be measured not only at rest, but also with exercise. CW Doppler can be performed during supine or upright bicycle exercise or immediately after treadmill exercise. This is a continuous wave examination from the same patient with the Starr-Edwards mitral prosthesis. Supine bicycle exercise was used, and the heart rate increased from 62 to 90 per minute. In real time, you will notice that spectra are intermittently lost due to increased respiration. Note that early and atrial velocities have only slightly increased with exercise, but there has been a significant reduction in the diastolic flow period, so that the mean gradient has increased from the resting value of 4 to 7 millimeters of mercury. With exercise, the pressure half time has decreased from 136 milliseconds to 121 milliseconds, which correlates with a slight increase in the calculated mitral valve area from 1.6 to 1.8 square centimeters. This slight increase in effective orifice area is expected with the increased cardiac output during exercise. Recent studies have raised concern that the pressure half-time method overestimates the true effective orifice area for mitral prostheses. You should be prepared to calculate the effective orifice area by an alternative method, particularly when you find a mean mitral gradient that is higher than you would expect for the pressure half-time valve area. For patients without aortic regurgitation, the continuity equation can be applied to mitral prostheses in a manner very similar to that which we described for aortic prostheses. The diameter of the left ventricular outflow tract is measured from a systolic freeze frame and converted to LVOT area as we previously discussed. From apical long axis, the velocity spectrum from the LVOT is recorded by placing a PW sample volume just below the aortic valve. Using the continuous wave mode, we record the velocity spectrum from flow across the mitral prosthesis. From the continuity equation, the mitral prosthesis effective orifice area is equal to the LVOT area times the LVOT time velocity integral divided by the mitral TVI. Note that in this case, the LVOT TVI must be used. One does not have the option of simply using the peak LVOT velocity. This patient has Starr-Edwards tricuspid and mitral prostheses. Here, the non-imaging transducer has been angulated toward the tricuspid prosthesis. These signals can be distinguished from mitral signals by the characteristic respiratory variation. You'll recall that the tracing from the nasal respirometer rises with inspiration and falls with expiration. Compared to expiration, inspiratory cycles show an increase in early peak velocity as well as an obvious increase in mean gradient. These signals are from the mitral prosthesis. While there is a slight variation with cycle length, there is no increase in the velocity spectrum with inspiration. Now that we have discussed normal Doppler hemodynamics for prosthetic valves, we must emphasize the importance of obtaining baseline studies for future comparison. Following implantation of a prosthetic valve, it is mandatory that a routine echocardiographic study should be obtained upon hospital dismissal or within the first 1 to 2 months post-op. Having discussed imaging and Doppler hemodynamics for normal prostheses, we will now turn our attention to the echocardiographic identification of prosthetic valve pathology. We will begin with a discussion of pathologic prosthetic valve stenosis. Thrombosis and pannus formation are the two most common causes for pathologic stenosis of mechanical prostheses. Bioprostheses most often become stenotic because of cusp degeneration and calcification. This patient presented with increasing dyspnea and cough 9 years after implantation of a 21 millimeter Bjork-Schiley aortic prosthesis. By echo, we discovered that she had moderate mitral stenosis and severe tricuspid regurgitation. At the same time, we noted dense echoes in the region of the aortic prosthesis. In real time, you will notice that motion of the reverberations within the aorta seem reduced. The maximum Doppler velocity spectrum was obtained with a transducer in the apical position. The maximum velocity across the aortic prosthesis was 5.1 meters per second, and the mean gradient was 56 millimeters of mercury, both of which are significantly increased for a 21 millimeter Bjork-Schiley prosthesis. At surgery, pannus ingrowth on the undersurface was found to significantly obstruct the prosthesis. This patient presented to us 4 months after implantation of Omniscience mitral and aortic prostheses. The Omniscience valve is another type of tilting disc prosthesis. This patient had developed orthopnea, and her chest x-ray showed pulmonary edema. Her aortic prosthesis had normal hemodynamics by Doppler. In this apex up 4-chamber view, you see the usual reverberations from the mitral disc in the left atrium. In real time, you will see that the disc motion appears reduced. Color flow imaging also suggested stenosis of the mitral prosthesis, because the diastolic jet was narrow at its origin and quite eccentric. Using a duplex CW transducer, the mitral diastolic velocity profile was recorded with an early peak of 2.7 meters per second. The mean gradient was increased at 20 millimeters of mercury, and the pressure half-time was markedly prolonged, 250 milliseconds. Transesophageal echocardiography was performed. With the transducer behind the left atrium, the disc reverberations appear in the left ventricle. In this diastolic frame, the opening excursion of the disc is significantly reduced. The reduced opening angle of the Omniscience prosthesis is even more evident when it is compared to the normal opening angle of this Bjork-Schiley mitral prosthesis. At surgery, the Omniscience valve was found to have a large thrombus, which was inhibiting disc opening. Patients with prosthetic valves can manifest subaortic obstruction, which can be diagnosed by echocardiography. For aortic prostheses, the subvalvular stenosis is dynamic due to left ventricular hypertrophy that developed before implantation of the prosthesis. Mitral prostheses can actually cause LVOT obstruction. Patients with valvular aortic stenosis can develop asymmetric hypertrophy, resulting in a Venturi effect with dynamic subvalvular obstruction. This dynamic obstruction will persist after aortic valve replacement unless a myotomy-myectomy is also performed. This patient was studied while recovering from implantation of a bioprosthetic aortic valve. The septum is hypertrophied, and there is systolic anterior mitral motion. The CW exam demonstrates a late peaking systolic profile typical of dynamic LVOT obstruction. The maximum velocity is 4 meters per second, which means that despite the aortic prosthesis, this patient still has a maximum instantaneous gradient of 64 millimeters of mercury across the LV outflow tract. This patient has a tilting disc mitral prosthesis. Her native aortic valve is normal, but notice how the mitral sewing ring narrows the LVOT. The maximum velocity across the LVOT was 4.8 meters per second, with a mean gradient of 51 millimeters of mercury. This lesion should always be included in the differential diagnosis of a systolic murmur that is heard soon after mitral valve replacement. We will now discuss prosthetic valve regurgitation, beginning with aortic prostheses. Prosthetic valve regurgitation can be transvalvular, perivalvular, or a combination of both. For bioprostheses, transvalvular regurgitation most commonly results from cusp degeneration. For mechanical prostheses, transvalvular regurgitation most commonly results from thrombus or pannus ingrowth. Regurgitation can also be caused by change in the shape of the poppet or disc, which is referred to as poppet or disc variance. Aortic prosthetic regurgitation can usually be fully assessed by surface echocardiography. The jet is directly below a transducer placed in the left peristernal position, and it comes directly toward a transducer in the apical position. From these positions, the sound beam can interrogate the jet without having to cross the prosthesis. As with native aortic regurgitation, complete assessment of the regurgitant aortic prosthesis requires an integrated approach. Color flow imaging allows us to assess the extent of the jet relative to the left ventricular outflow tract. The color flow exam is supplemented by continuous wave Doppler. We pay attention to the signal strength of the regurgitation, and we use CW to measure the aortic regurgitation pressure half-time. By pulsed wave Doppler, we assess the amount of reversal in the descending aorta, and we also check for reduction in the mitral pressure half-time and for diastolic mitral regurgitation. 2D and M mode are used to assess the functional significance of the regurgitation via analysis of LV size and function. This patient has Starr-Edwards mitral and aortic prostheses, which appear normal by the 2D exam. A regurgitant jet can be identified originating from the aortic prosthesis. However, it is difficult to be certain about the jet dimensions because it merges with the diastolic jet from the mitral prosthesis. The spatial extent of the color jet is best appreciated from the peristernal short axis view. This is the left atrium, And this is the left ventricular outflow tract, just below the level of the aortic sewing ring. The aortic regurgitation jet area is small compared to the LVOT area. This patient has Bjork-Scheele aortic and mitral prostheses. This is a remnant of the mitral support apparatus. The mitral and aortic discs open and close normally. This is an expanded parasternal long axis view of the mitral and the aortic disc prostheses. This is the LVOT. A small color jet of periprosthetic aortic regurgitation arises from the anterior portion of the sewing ring. In parasternal short axis format, we can appreciate that the aortic regurgitant jet actually occupies nearly 1/2 of the circumference of the sewing ring. We felt that this was moderate regurgitation, but it is difficult to be confident with this unusual jet shape. The CW envelope of aortic regurgitation was easily obtained and fully defined, although the regurgitant signals are less intense than the forward flow signals. Pressure half time of aortic regurgitation was 486 milliseconds, which is also consistent with the assessment of moderate regurgitation. This patient had a mitral annuloplasty and implantation of a heterographed aortic prosthesis. These are the stents. The valve had degenerated. This cusp is torn, and it is prolapsing into the left ventricular outflow tract. In systole, mitral regurgitation fills the left atrium, and a broad jet of aortic regurgitation fills the LVOT in diastole. An M-mode cursor has been placed across the LVOT and the left atrium. The color M mode shows aortic regurgitation filling the LVOT in diastole and mitral regurgitation filling the left atrium in systole. This is a parasternal short axis view in diastole. Color signals in the left atrium are from pulmonary venous inflow. The aortic regurgitant jet completely fills the LV outflow tract. This patient has a ball cage aortic prosthesis. This is the cage within his enlarged aortic root. The prosthesis rocks freely, indicating a large dehiscence. This is the aortic prosthesis. The sewing ring has separated from the aortic annulus, which is here. The prosthesis has rocked into the LVOT. This will be more apparent in real time. While we suspect that aortic regurgitation is severe, it is difficult to precisely define the color jet because of the rocking mechanical prosthesis. This is the descending aorta, imaged from the suprasternal notch. In this diastolic frame, reversed flow fills the aorta, confirming the severe degree of prosthetic aortic regurgitation. A sample volume has been placed in the descending aorta. The diastolic reversal is high velocity, 0.5 meters per second, and persists throughout diastole, again supporting a diagnosis of severe aortic regurgitation. As final confirmation, the severe aortic regurgitant jet has a pressure half-time of only 222 milliseconds. This case clearly illustrates how 2D, color flow, PW, and CW exams are combined to arrive at an accurate assessment of the severity of prosthetic aortic regurgitation. As with prosthetic aortic regurgitation, prosthetic mitral regurgitation can be either transvalvular or perivalvular. The assessment of prosthetic mitral regurgitation by surface echocardiography is often very difficult, both because the left atrium is a long distance from the transducer and because the prosthesis itself attenuates the sound beam before it can reach the left atrium. Therefore, the assessment of mitral prosthetic regurgitation has become one of the prime indications for transesophageal echo. We will discuss first surface echo and then transesophageal echo for the diagnosis of prosthetic mitral regurgitation. Color flow imaging is used to assess the spatial extent of the mitral regurgitant jet within the left atrium. In addition to apical views, it is important to obtain peristernal and off-axis views in an attempt to direct the ultrasound beam into the left atrium without crossing the mitral prosthesis. This 62-year-old male has a Starr-Edwards mitral prosthesis. Color flow imaging was initially performed in the plane of the mitral poppet. No regurgitation was identified within the left atrium. The transducer was tilted inferiorly to the level of the sewing ring and laterally. A jet of mild periprosthetic mitral regurgitation is readily apparent. This 80-year-old male also has a Starr-Edwards mitral prosthesis. On auscultation, mitral regurgitation was suspected. The left ventricle is mildly enlarged and function is severely reduced. In this case, neither scans in the plane of the poppet nor scans at the level of the sewing ring demonstrated regurgitation. You will notice that with an apical transducer location, the ultrasound beam has to pass through the mechanical prosthesis before it can interrogate the left atrium for regurgitation. This is a parasternal long axis view from the same patient. This is a very useful view for assessing mitral prostheses for regurgitation, since at least part of the beam can be transmitted to the left atrium without first striking the prosthesis. This is the parasternal long axis view, with color flow demonstrating at least moderate perivalvular mitral prosthetic regurgitation. Continuous wave Doppler should always be utilized when assessing patients for prosthetic mitral regurgitation. CW Doppler often provides the first clue to the presence of regurgitation. In addition, the signal strength of the CW regurgitation is an important clue to the severity of the regurgitation. This 76-year-old male has a mitral tilting disc prosthesis. The disc excursion is normal, and LV function is mildly reduced. The color flow examination initially suggested mild prosthetic mitral regurgitation. Mitral regurgitation was easily detected by CW Doppler. Furthermore, the signals of regurgitant flow are almost as intense as the signals of forward flow across the prosthesis, which suggests that the regurgitation is severe. This is supported by the increased velocity of forward flow, 2 meters per second, with a normal deceleration slope or half time. The findings by CW Doppler led to reevaluation by color flow, utilizing slightly different tomographic planes. This is a scan at the level of the sewing ring. In this plane, we see a severe periprosthetic leak. The broad color jet strikes the back wall of the atrium and splits in two. This patient had Starr-Edwards prostheses in the mitral and aortic positions. She was referred to us with an echocardiographic diagnosis of obstructed aortic prosthesis. The mitral prosthesis appeared normal on 2D exam. This is a diastolic frame showing LV inflow around the mitral poppet. Our initial color flow exam from both apical and parasternal positions showed no mitral regurgitation. Our CW examination confirmed obstruction of the aortic prosthesis. Note the clear isovolumic relaxation period, which confirms that these signals are from flow ejected across the aortic prosthesis. The maximum aortic velocity was 4.9 meters per second, and the mean gradient was 52 millimeters of mercury. A slight lateral tilt of the transducer yielded these systolic signals, which have a peak velocity that is nearly identical to that of the aortic peak velocity. However, you will notice that this flow is holosystolic. These signals are due to unexpected prosthetic mitral regurgitation. This is the mitral regurgitation recorded at a faster sweep speed. The strength of the CW envelope suggests that this is a significant amount of regurgitation. Because of the CW exam, color flow imaging was repeated using a modified apical four-chamber view. An intermittent jet of mitral regurgitation was identified, but the jet area was felt to likely underestimate the severity of regurgitation. This is a transesophageal study from the same patient. With the transducer in the esophagus, the left atrium can be inspected without interference from the prosthesis. Severe perivalvular mitral regurgitation was identified. This was confirmed at surgery, and the mitral prosthesis was replaced, in addition to replacement of the obstructed aortic prosthesis. This 54-year-old female experienced increasing dyspnea, and a loud systolic murmur was noted on physical exam. The bioprosthesis leaflets were difficult to image by surface echo, but one cusp did seem to prolapse beyond the sewing ring. This is a parasternal short axis view. Aorta, atrial septum, left atrium. Color flow imaging demonstrates a jet of mitral regurgitation that is directed beneath the aorta and around the remnant of the left atrial appendage. The small image is an apex-down four-chamber view. These are the mitral prosthesis stents. The pulsed wave sample volume has been placed in the left atrium near the sewing ring. Mitral regurgitation is identified with unusual vibrations within the systolic envelope. In real time, you will hear these vibrations. This is the CW Doppler exam, which also shows unusual vibrations within the systolic envelope. Listen again to the angry bee murmur that is typical for a torn cusp. The patient's mitral prosthesis was replaced. Prior to replacement, intraoperative transesophageal echocardiography demonstrated the torn cusp. In real time, you will see this vibrate, and you can imagine it producing the angry bee murmur. The last two studies have shown how transesophageal echocardiography can delineate prosthetic mitral regurgitation, whose presence or severity is not expected from the surface color flow exam. Because of its importance in diagnosing prosthetic mitral regurgitation, we would like to illustrate the use of TEE for two additional cases. This is a transesophageal study from another patient with a mitral heterograft prosthesis. These are the stents. In this systolic frame, you can see that the leaflets do not coapt properly. Color flow imaging reveals severe transvalvular regurgitation, which splits into two separate jets. This transesophageal study is from a 62-year-old male with a ball cage mitral prosthesis. In systole, you can appreciate the closing volume that is displaced into the atrium as the ball moves toward the sewing ring. This is a scan toward the atrial septum. Periprosthetic regurgitation is identified at the medial edge of the sewing ring. Scanning laterally, diastolic flow from left atrium to left ventricle is noted through a second periprosthetic defect. In systole, a broad jet of mitral regurgitation originates from this defect. Both mechanical and bioprosthetic valves are subject to infective endocarditis. Because of multiple reverberations, it is difficult to diagnose mechanical prosthesis endocarditis by surface echocardiography. But transesophageal imaging allows us to detect mechanical valve vegetations. We will now illustrate such a case. Infective endocarditis can lead to valve ring abscess, a complication which will be discussed subsequently, along with other abnormalities of the valve bed. This 64-year-old female developed Staph aureus endocarditis 19 years after implantation of a Starr-Edwards mitral prosthesis. Surface echocardiography did not reveal any vegetations. Therefore, a transesophageal study was performed. This is a systolic frame. The cusps of her native aortic valve are slightly thickened. The mitral ball is seated at the sewing ring, and this is a vegetation. You will appreciate mobility of the vegetation in real time, and you will also see a swirling pattern of flow within the left atrium. This vegetation, attached to the sewing ring, was confirmed at surgery when this prosthesis was replaced. In addition to delineating abnormalities of prosthetic valves, echocardiography can also be used to diagnose abnormalities of the valve bed to which the prosthesis is attached. These abnormalities include valve ring abscess, pseudoaneurysm, and aorto to right atrial fistula. We will now illustrate each of these. This patient developed infective endocarditis with staph epidermidis a few weeks after his aortic valve was replaced with a Starr-Edwards prosthesis. One of the dreaded complications of infective endocarditis is valve ring abscess formation. Transesophageal echo is well suited to making this diagnosis, which is an indication for surgery. This is a nearly short-axis view of the aortic prosthesis, and this is the abscess cavity which surrounds the prosthesis sewing ring. This patient developed Listeria endocarditis 1 year after implantation of a Carpentier-Edwards aortic prosthesis. These are the stents of the prosthesis. This is an abscess cavity adjacent to the aortic root. There is debris within the cavity. Communication of the abscess with the left ventricle is apparent here. This is a small vegetation attached to a cusp of the aortic prosthesis. Note the systolic expansion of the abscess cavity. This is an expanded view of the abscess cavity. This is a systolic frame which demonstrates mild mitral regurgitation. During ejection, the abscess cavity has filled with mosaic signals due to communication of the cavity with the aorta. In diastole, there is continued flow into the abscess from the aorta, and in addition, we see the exit of flow from the abscess into the left ventricle. This is an expanded view of the annular abscess. This patient has a ball cage aortic prosthesis. On this apex up long axis view, you can see that the prosthesis has dehisced. There is separation of the sewing ring from the aortic root to which it was originally sewn. This is a parasternal short-axis view of the prosthesis and left atrium. This is the atrial appendage. This cavity adjacent to the prosthesis is a pseudoaneurysm, which communicates with the aortic root and is lined only by adventitia. This is an expanded view. This 39-year-old female has a Starr-Edwards aortic prosthesis and had a murmur felt to represent periprosthetic aortic regurgitation. This is the sewing ring of the prosthesis, and this is the aortic root. Color flow imaging demonstrates that there is periprosthetic regurgitation into the left ventricle. It also demonstrated the unexpected finding of a shunt from the aortic root adjacent to the sewing ring to the right atrium. On this tape, we have emphasized the need for a systematic integrated echocardiographic approach to patients with prosthetic heart valves. The 2D examination is difficult for prosthetic valves, but may still uncover abnormalities such as dehiscence of the sewing ring. Spectral Doppler provides precise measurement of prosthetic valve gradients and effective orifice areas. With a combination of spectral Doppler and color flow imaging, we can detect and semi-quantitate prosthetic valve regurgitation. This can usually be accomplished with surface echocardiography for aortic prostheses. The new window provided by transesophageal echocardiography allows us to diagnose and semi-quantitate prosthetic mitral regurgitation and is also of great value in imaging valve bed abnormalities such as ring abscess. In conclusion, accurate diagnosis of prosthetic heart valve dysfunction has traditionally been an exceptionally difficult clinical task. However, echocardiography has developed to the point where it can delineate most problems related to valvular prostheses. By using a systematic approach that integrates information from the 2D exam, spectral Doppler, and color flow imaging, the echocardiographer can non-invasively diagnose the majority of patients with prosthetic valve dysfunction. Exceptions include prosthetic mitral regurgitation and aortic root abnormalities. But with the addition of transesophageal echo, even these obstacles have been overcome. By utilizing this full range of echocardiographic capabilities, patients can be selected for surgical correction without requiring invasive hemodynamics.